Hello, everyone. This is Cole Lyons again, coming from the American Journal of Healthcare Strategy. And here with me is Rachael Smith. Rachael, why don't you share a bit about yourself?
Yeah. So my name is Rachael Smith. I'm currently located in Philadelphia, Pennsylvania. I am a dietitian by training. I got my bachelor's degree at LaSalle University, where I, pursued a bachelor's degree in nutrition. I fully was on the track to be a registered dietitian. I did that for a few years, starting my career in the cardiac ICU. I had a kind of slew of experiences in that position that I'm sure we're going to get into today. And then I went back to get my master's degree at Penn State in healthcare administration, just kind of deciding that after having those experiences, I wanted to learn as much as possible about the industry. There I learned about, value-based care, ACOs, population health, and so many different light bulbs went off in my head. And while I was there, I decided to pursue an administrative fellowship within value based care. And I ended up at the Delaware Valley ACO, where I'm about 3/4 of the way through my administrative fellowship.
Nice. You've had a really incredible journey, and I think it's also a really unique one. And you're probably going to have a lot of perspectives that you'll be able to share on maybe how we can improve education and improve healthcare from a lot of different areas. What I want to kind of understand first is what led you to take that, it's a lot of hard work to go back to grad school and it costs money to go back to grad school, but there's always that opportunity cost of well of switching from a career you already had connections and experience in to then go into administration. So what kind of led you to make that decision?
So I'll kind of start off by saying when I was switching, when I made the decision to go back to grad school and I had all of this clinical experience, my perspective was that I would be kind of starting from behind. I thought I was working from a disadvantage, having clinical experience rather than, a lot of people who I already knew were in MHA programs who had bachelor's degrees in healthcare administration. I thought having mostly a clinical background would actually hinder me. Really quickly, I learned that, through a lot of encouragement from from the faculty at Penn State, that may not be the case, and it really all came down to how I positioned myself in the field. So one thing I would say to anyone thinking about going back to school after they've already started a clinical career is that it can really be an advantage, and it really kind of uniquely sets you up for a career in administration. So all of that to say, I had always. Oh, sorry. Go ahead.
No, no, sorry. I was going to say, one of the things that comes to mind is we need more people in, coming from clinical specialties to be in administration. How do you think, as educators at institutions like Penn State, they did a great job at making you feel welcome. How do you think other institutions could do that? How can we make clinical professionals feel more welcome?
Mhm. I think anyone who has worked in, especially, a large health system has seen that kind of phenomenon where we, have really, really high performing clinical professionals. They're really great at their clinical roles, and then they get promoted into these leadership, management, administration careers. And for some people, that is a really great fit. They are natural born leaders. They have really great management talent, but maybe they haven't had the training to really succeed in those roles. And, that didn't happen for me. So I don't know what the outcome for me in that situation would have been. But I think something that we can do as leaders is just in the clinical space, really encourage people to get that formal management leadership education. And something that was a little bit different for me as a dietitian that I'm not sure is present in, say, nursing, for example. I think in the nursing profession, something that they do really well is encourage nurses to go back to school, participate in these administrative functions, get leadership training. I see it all the time. I have tons of colleagues who are nurses. I have tons of career role models who started their careers as nurses, physical therapists, occupational therapists, etc., who they got a lot of encouragement early in their clinical careers to take on these administrative tasks or roles to be able to build those, to kind of build that skill set. I didn't feel that way in my early career. There weren't a ton of opportunities to take on administrative roles or leadership opportunities. In my experience, there was kind of a team of clinical staff, and then one administrator for that whole team. And that was kind of it. That was the leadership structure. So there wasn't a whole lot of upward mobility within that structure. And from conversations that I've had with colleagues during that time, that seemed to be the case across the industry. I can't speak for the industry, nationwide, but at least in the other settings that, I have colleagues in, that seemed to be a pretty common experience. So I had always, planned to go back to grad school. And when I had experienced this type of limit to upward mobility and not a lot of opportunity to improve those leadership and management skills, and wanting to learn as much as I could about the healthcare industry, because it just being in it as a clinical person, I still had so many questions. It was still so overwhelming and complicated to me. It seemed like an MHA was the perfect fit.
I think when you think about it, it makes sense because a lot of the MSNs and especially like the DNP programs for nurses, they have a leadership component, and some of them are like
Mhm.
entirely leadership focused. Do they? I don't think a lot of the masters in what is it, dietetic? What's it
Mhm.
called?
Yeah,
The
dietetics is great. Yeah.
Yeah, the master's programs for yeah, they don't necessarily have a leadership component to them, right?
So I did not get my master's in nutrition. That is an industry standard now. So I believe the in 2024 or 2023 it is a requirement, but when I graduated in 2019 it wasn't. And still the requirement is that you need to have a master's in something. It does not have to be a master's in nutrition to be a registered dietitian. But just to keep up with industry trends, myself and a lot of my colleagues were, going to get our master's degree just to be able to stay competitive in the market, right? So, but you're completely right. There, in my bachelor's degree, there was not a focus on that, where I know a lot of undergraduate nursing programs there is, and just visibility, right? When you're in a large hospital system, there are senior and upper level management who all have RNs behind their names, right? So it's very visible that a lot of leadership comes from RNs who have worked at that hospital and on the floors of those hospitals for years and years. And that's just not something that was really present, or that I had seen was present with dietitians.
Yeah, that makes a lot of sense. I think that can be a challenge too for physicians as well, where I think often they're taught to manage physicians, but they're not always taught how to manage different clinical staff. Whereas if you're a nurse, sometimes as a nurse, you're helping to manage the younger physicians, you're helping to manage the you know janitorial staff, the maintenance staff. You're kind of helping to manage a lot of these areas, and you have to be skilled in that. But then everyone else doesn't always get that, and so that makes a lot of sense on why that MHA would be valuable. But I guess what I'm wondering as well is, you know why, what about you was attracted to actually being in leadership, aside from, I guess sometimes clinical staff dislikes administration, they dislike leadership, and sometimes they're, a little worried about kind of joining that kind of group of administrators. But you kind of had approached it with a very different mentality, and I'm wondering, were there any leaders that you saw or any opportunities that you saw where you were actually really attracted to leadership and you saw it as an avenue where you could help patients even more?
Yeah. So early on in my career, I there were a lot of leaders that I saw who were really inspiring to me, who were doing really, really great work to just kind of improve the lives of patients. On one hand, that kind of motivated me. On the other hand, just being kind of a staff dietitian, not having a huge span of influence, there were a lot of problems that I were seeing for patients, right? I mentioned that I was working in the cardiac ICU. There were a lot of services and things that I knew about, both from my education and from, other colleagues in the field, that, there were things out there that I knew existed, could help patients, that didn't exist in the setting that I was working at. So I was kind of spinning my wheels, trying to get these programs created or new workflows created to better help patients. But having such a limited span of control that I had, it was really, really difficult. And so that kind of motivated me to not just try to amass more seniority or more influence for myself, but also reach out to other leaders in the organization to try to help me understand the kind of how the system worked so I could get these programs better working for patients. And then once I realized how the whole system works or how complicated it was, it's a system that I care a lot about for a lot of reasons. That's a whole other conversation. But healthcare being a system that I care so much about, whenever I care so much about something, I kind of want to get in and help as much as possible. And the position that I was in, I didn't feel like I had a capacity to help as much as I knew that I could. So when I was communicating with all of these different leaders who could help me with these programs, I was really inspired by all of the work that they were doing. But I also wanted to get to a place in my professional career where I was similar to them and was able to kind of enact these programs, try to take down barriers. And we were just, as dietitians, trying to do the best that we could for our patients. And if there wasn't someone at the management level, like kind of listening to us and helping take away barriers, there really wasn't a whole lot we could do. So I was thinking, all right, look at these leaders who are doing a great job, try to duplicate what they're doing, but also get yourself in a professional capacity to where you're able to do those things.
And I think, that's a humongous motivation. I think that goes along with what you were saying earlier on why you chose to go in this direction. And so with that kind of humongous motivation, why did you choose Penn State? What was the reason for
Mm-hmm.
going with their MHA program amongst, a lot of the others in our region?
Mm-hmm. So there's a lot of different answers to that. And I alluded to it in the written responses to the questions that I submitted earlier, but I am born and raised from central Pennsylvania. So part of it was, they were very forefront on my radar. I grew up going to Penn State games when I was a kid. My mom is a very proud Penn State alum. So, that was one reason that they were kind of on my list. But there were a bunch of universities on my list, a bunch of different programs that I was looking at. But the reason why I ended up choosing Penn State and why I really kind of went after that program really solidified for me the first time I met the program director, Dr. Chris Calkins. He is just an incredible human being. And the first time that I met with him and his colleague, Aileen Galley, who is, again, just wonderful, it just came across so clearly in that first meeting how much they truly care about every single student holistically. They care about the well-being of every single student, both in the classroom and also in their careers. So most of my cohort were early to mid-career professionals. And like I had mentioned before, they took the time to really understand where each student was in their career and how that career experience made them a unique part of the cohort who had a unique set of experiences to offer the industry. So I wasn't just someone pursuing an MHA degree. I was, someone who already had a degree in nutrition, has a really unique background, had done 3 years in a cardiac ICU as a dietitian, I'm coming from this unique background, and they from day one were thinking about how to uniquely position me in the field while also taking an interest in my emotional and educational health and well-being throughout the entire program, and how I would fit into the cohort as well. And that just very clearly came across in that very first meeting. And ever since then, I was like, okay, this is where I want to be. This is where I want to spend the next 3 years. These are the people that I want to spend the next 3 years with. And it was very clear from that first meeting.
Yeah, that's great. You can always tell. I mean, that's one of the reasons why I've stayed with Jefferson, because, I've just met people that have really motivated me and that I've wanted to stay with. And so I understand that feeling for sure. I think one of the questions as well is, you've gone through this MHA program at Penn State. Would you go back and change anything about your undergrad experience or your major?
Um, I have to think about that one. I think if there was one thing I could go back and change about my undergrad experience, I wouldn't have changed, the outcome, because, like I said, I think it makes me, it kind of makes me a unique. It puts me in a unique position in the field, right? And I do want to just explain a little bit about what that education entailed. So, to be a registered dietitian, you have to go through three different kind of sections of the degree. One of them being food service management, one of them being clinical, so you have to understand how to treat different conditions with nutrition, and then one of them being uh, community. And community nutrition is what always kind of attracted me the most. And that's where I first learned about social determinants of health, the social ecological model, things like that, how health systems and governments and even the family structure really work together. And that's kind of where I learned that I cared so much about population health before I knew to call it population health. I didn't learn that term for a while, but that's when all of that sort of language and those concepts really started speaking to me. So if I didn't have that basis and that background, when I got to grad school and learned about ACOs and value-based care and population health, I'm not sure I would have had the language or the knowledge to pursue that. And also, like I said, my clinical experience has been invaluable when it comes to even the work that I'm doing now. So in my kind of day to day with the ACO, I work a lot with our clinical strategies team, with our quality team, with our patient transfer or our practice transformation team. And I would not be able to do the work that I do at the level that I do if it weren't for those experiences in a patient care environment. And we had talked a little bit earlier about that kind of disconnect between clinical staff and administration and how important it is for those two groups to really understand each other. And that is done the best when each group has a little bit of experience in the other group, right? So I feel like I have a certain level of skill when it comes to connecting with clinical stakeholders, because at one point I was a clinical stakeholder. I feel like I can communicate certain needs that we have in the ACO to clinical staff, because at one point I was a clinical staff member who was being told that I needed to do things that I didn't understand why I had to do them. So I feel like I can speak that language a little bit better than someone who didn't have any clinical experience. So I see my path as a little bit curvy and windy, but I'm not sure I would have done it any different.
I think you and I are both really invested in value based care, and that's one of the areas where there's sometimes the biggest disconnect, because we're kind of shifting the value proposition, it might appear initially, away from direct patient care, even though in reality we're actually trying to improve patient care. But sometimes there's that communication disconnect where the clinical staff will feel like they're being hamstrung in some ways, they're not able to do what they used to do. And then sometimes the administrative staff is under extreme pressure, but once everyone's able to communicate, everyone realizes that it's really just trying to do its best for the patients. What was going into that program with the Delaware Valley ACO like? Because I assume that you probably already knew a good bit about value-based care, but I'm familiar with the Delaware Valley ACO, but I actually don't know everything that they do. So what was that like? Was there a huge learning curve? What did you learn? And if you could explain to all of us what the Delaware Valley, excuse me, ACO does, I'd love to hear about it.
Yeah, so there was definitely a huge learning curve when I joined the organization, and I still feel like I'm learning every single day. The reason why I pursued the ACO and a fellowship in general is because in my graduate program, I felt like there wasn't enough education on value based care and population health in general. And I really do just feel in my bones that that is where the industry is headed for a lot of different reasons that, again, could be a whole separate conversation. But I really do feel like that's where the industry is headed. And because I feel that way, I was surprised that there was so little discussion of value based care in my graduate degree program. And I just felt like I had so much more to learn. So I was looking for administrative fellowships in value based care. I was lucky enough to secure one of the very few fellowships in value based care at the Delaware Valley ACO. And very much from the beginning, my posture was just learn and absorb as much as physically possible. And at the very beginning, I was lucky enough to attend the Jefferson population health boot camp, which was so incredibly educational. And I had met a former CEO of Delaware Valley ACO, and he had said to me, I think, with your background, I think you're going to have a pretty smooth transition. Compared to other fellows. And that had me feeling really good about myself. So I, was like, okay, this won't be too bad. I won't be too in over my head. I'll be okay. And I was wrong. I
Right.
was very overwhelmed. It was a lot of learning. It was a huge learning curve. Everyone at the Delaware Valley ACO in the very beginning, whether it's a fellow or a new mid or senior level manager, describes it as drinking from the fire hose. In the very beginning, it's just a lot of information, a lot of new language. So it's just a lot. And I'm still learning every single day. And just the way the organization is structured and our different priorities is just still something that I'm learning every single day. But the way I like to describe it to my friends and family when they ask me what I'm doing is really just that we at the Delaware Valley ACO are one of the players trying to shift the industry from paying for volume to paying for value. That's really what we're doing in the clinical space. And we do that by just focusing on the patients in our network. So by trying to avoid changing the entire industry overnight, we have the patients in our network and we are just focused on keeping them healthy, keeping them out of the hospital, promoting their health to the best of our ability, and making sure that payment structures are set up so that we are paying their providers for the quality of care that they provide rather than the volume, and also trying to decrease the amount of healthcare volume that the patients need. So that's by doing, health outreach, making sure that they are all seeing their preventative care physicians as much as possible, like their primary care physician, things of that nature. But we're essentially just trying to use innovative payment structures and keeping patients healthy so they don't have to access traumatic forms of healthcare like an emergency room visit, or costly forms of healthcare, also like an emergency room visit. But that's really what we're trying to do. And there's a whole lot of ways to do that, but that's the long and short of
Nice.
it.
Yeah, that's very inspiring work, and I love that work as well. And I've had a similar experience with, I was doing outreach for population health, and then I went over to the payer side because my mentors were telling me, move over to the pair side. You're it's not going to be too challenging. You're going to do great because you've already been doing good with outreach. And then all of a sudden, like each plan has a book, like 100-page book that you got to kind of understand. And there's all these nuances and, very unexpected, but it's, that gaining of knowledge that's really rewarding. You already alluded to it that you really think value-based care is where things are going. Right now we're in this position with it where people are kind of saying it's going to fully overtake fee for service, that it's going to transform everything. And then other people say it's just going to, come around, be here for a little while until something else comes out in terms of the payment models. What kind of place are you in with that?
I would consider myself, I guess, a hesitant optimist. I wouldn't say that value-based care is going to completely take over fee for service, at least, not in my lifetime. There will always be those patients who, because of their position in society, their socioeconomic status, their particular health needs, who prefer the fee-for-service model, and providers who prefer the fee-for-service model, and that's right for them. What I hope to see in my professional career before I retire is just that value-based care becomes more mainstream. I find myself constantly having to describe what value-based care is and what population health is and what the benefits of it are, both to healthcare consumers and healthcare providers. And I wish that wasn't the case. I wish providers especially understood the benefits of it for both the health of a population and also just the health of individuals. That's where I wish we could get to. I'm not going to go so far as to say that it will become the new normal, but I am optimistic that it will become more mainstream. But I don't see fee for service ever going away, but I think it will be beneficial really for the health of our nation that value-based care becomes more mainstream and more just understood by the general public of healthcare consumers and providers.
Definitely. I'm in the same camp, I think. I hope that it really goes far, and I hope that eventually it becomes kind of the standard. I actually am even a bit more probably zealous for it. I think that, fee for service can really kind of go to the wayside, especially if we don't want nationalized healthcare. We need to have a method that changes the way things are paid for. I wanted to kind of leave off with maybe some recommendations that you'd have for grad students. You've been so successful. Your mentors are kind of praising you. So what would you recommend new graduate students or people who are just ending their graduate program so that they can have a really successful career like yourself?
Mm-hmm. I will say also, to your last point about graduate programs and doctoral programs in population health, one of the things that I think was helpful to me pursuing a master's of healthcare administration, which was so broad, and then pursuing a career in population health, was that it's not enough just to be an expert in population health. You really just have to have motivation and a drive to understand as much as possible about the industry as a whole. And that was something that was part of my motivation to pursue an MHA to begin with. I didn't want to, I thought about a lot of different degree programs, and I didn't want to pigeonhole myself, but more than that, I really just wanted to learn as much as possible about the industry as I could. And while I think, programs specific to population health are incredible and advance, the discipline and the field of study, I do think it's important to know as much as you can about the traditional way things are done, because that'll also help us advance population health and value-based care as well. So that would be a recommendation that I have for recent graduates as well. Just learn as much as you possibly can about all of the different ways things are done. And, even though I fully believe that value-based care is where we're headed as a nation, I am still every day trying to learn all of the different small niches in fee-for-service medicine and how the industry is working now, because I think that's going to help us in population health have those conversations when we're trying to change minds and change attitudes, and all that good stuff. So that would be one recommendation, and that was definitely part of my motivation to pursue an MHA. But I also fully believe, and this was really good advice that I got from one of my professors at Penn State, who now teaches at the University of Kentucky in their MHA program. And she said, when I was early on in my master's degree, I was getting really antsy. So I was getting all of this really good education, all of this knowledge, but I was in this job where I couldn't really apply a lot of it. There was just not a lot of room for me to take what I was learning in the classroom and apply it in my current role. So I just felt like I had all of these things to do, but I didn't have a lot of place to do them. And she gave me the advice to just start cold calling. And this was some of the best advice I've ever given. And so many people who are watching this interview right now are probably rolling their eyes, but it's something that I really firmly believe in. Cold call, cold call, cold call. And now, lucky for us, it's cold emailing, not cold calling. But in those early days of my degree, I was cold emailing any person who I thought had a job title that I thought sounded interesting. And I would say, I am in my second year of grad school. I'm pursuing this degree. I think the work that you do sounds really interesting. Can I have 30 minutes of your time? And 9 times out of 10, they would say yes. And then we'd have a 30-minute Zoom call. One woman that I cold emailed, we ended up working together for the next 2 years. She sponsored my capstone project. We are still in communication to this day. She's a really good friend and colleague of mine. She's wonderful. Worst case scenario, you just have a really fun conversation and you can kind of picture yourself in the future doing something really interesting. So it just can open so many doors for you. I do it in my current job. I, will just cold email people on LinkedIn or in, the company that I work for, just to learn about what they do. And then they might introduce you to someone else. And it just kind of goes on from there. That partially introduced me to the DVACO fellowship because I cold emailed the former fellow. So it can be really inspiring just for yourself to feel a little bit better about where you are, either in your career or in your educational journey. And it can also open a lot of doors for you. So I can't say enough good things about it. And a few weeks ago, my boss and mentor and the director of the fellowship program that I'm in actually gave me the exact same advice. So 2 very important people in my educational and career journey have given me the same advice. So I think that probably means it's pretty good advice. So I'm passing it on to everyone else.
I think it's excellent advice, and I actually attribute it to the only reason I'm in, kind of the role I'm in now is I cold called people about the role. I had met with a lot of the people at Jefferson Health Plans because I, wanted to learn about what it's like over there. And, so I think it's an excellent method, especially if people are struggling to find mentors. You just start sending LinkedIn invites, start sending emails, and a lot of people are like really, really excited to share their advice. So it's great to see. One of the questions that I have, I think that's really important is, you're coming out of a good MHA program, you're coming out of the fellowship, you're a really valuable candidate with lots of knowledge, but sometimes these programs, or these companies rather, struggle to recruit people like yourself. What is something that, hiring candidates like yourself, that companies could attract you to work for them that could make the work experience better and the company more attractive for you?
So, of course, there are all of the check boxes that people look for when they're looking for a new position. And those check boxes are important. And, remote work comes to mind, flexibility with remote or hybrid working. And I bring that up not because it's just like a nice to have, but also because a lot of us, like myself, had some experience with learning or working during COVID. So not only did we get used to that because it was just a nice thing to have, but we also had to really develop skills to be able to do that, right? So it took some growing pains to be able to work or learn remotely, and now we have skills to be able to do that, which are not things that we want to have, falter or no longer have those skills. So that's one thing. But even more than that, I think something that organizations can do to go above and beyond in attracting new talent is having formal, like well structured mentorship programs. And I think there really is a desire among people in my age group, especially for young women and young people of color, is having someone that they can go to who has similar experiences to them, someone who looks like them, who's maybe a little bit further ahead in their career, that they can go to ask harder, maybe more uncomfortable questions, but also just, ask very blunt questions about their career trajectory. And that's not always something that you can ask of a coworker who's maybe a peer to you or your boss, right? And that can be a difficult thing to kind of forge on your own. I think it's an important skill for especially MHA grads to be able to make those connections on their own and forge kind of more informal mentorship relationships. So don't get me wrong, that is definitely something that you should be able to do on your own. But if I were to, interview with a company and they told me that they have formal mentorship, like structured mentorship programming, where they really invest in their young talent and they help you find a mentor, and that's something that they really believed in as a company, that would be a huge gold star to me. That would tell me that they really care about their younger talent and that they care about those relationships within their workforce, and that they care, explicitly about their, employees of color and their young women who are employed. So that's something that's, not monetary, that I think really goes above and beyond, because like I said, that's a skill that everyone should sort of have, but it's just such kind of like a weight off your back when it's not, when it's something that's kind of already done for you. And it's something that I know a lot of HR professionals like and are really good at set up.
At
Okay.
Jefferson Health Plans, we have the Rise Up program,
Mhm.
and we also have a leading edge leader. But then at Jefferson Health, they don't really have that, and you can really tell the difference in kind of how a lot. And there's a lot of reasons why Jefferson Health doesn't do that at the moment. I'm not saying anything bad about Jefferson Health, but the difference is pretty. You can see it because you're able to connect with a executive vice president or somebody in the C-suite and actually really ask them questions, whereas otherwise it's kind of, you feel a little bit more
Mhm.
isolated. And like you said, sometimes we need to ask blunt questions to people, and it's hard to ask that to your
Yeah.
peers. Well, thank you so much, Rachel, for joining us today. You provided some really amazing insights, and I'm sure everyone's going to really be able to glean a lot from this. I can't be more appreciative for you taking your lunch hour here to come and join us.
Of course. Thank you so much for having me. This was a really just, fulfilling conversation. I was glad to be able to do it. And I always love an opportunity to talk about the industry and value based care and my time at Penn State. So was more than happy to do it.
I'm sure we'll be having you back to talk more in depth about value based care. And hopefully, I'll be able to get kind of a few different people with different opinions on. We can all have a good discussion. So we'll definitely be seeing more of you down the road. All right.